So welcome to another session of the Adult Immunization Online Learning Series. I'm Dr. Endymion Tan, so I'll be discussing the Streptococcus pneumoniae infection as a vaccine-preventable disease. So these are the disclaimers of this lecture. So evidence summaries are based on the best available scientific evidence at the time of formulation of the guidelines. The executive summary, so in this lecture, we'll be talking about the different grading classifications. We'll talk about the recommendations, the scheduling of the vaccines, and the cost-effective studies for the two types of pneumonia vaccines. The quality of evidence, so they will be differentiated into the high, moderate, low, and very low. But of course, some evidences would show a very low or would have a lower quality of evidence because of some risk of bias, important inconsistency of the results, etc. Talking about pneumonia, so the pneumonia infection still would have a very high rate of mortality and morbidity, and as of the 2017 global data, this has the highest rate of infection in the older population, especially among those who are 70 years old and above. And in the Philippines, it's still one of the most common causes of mortality in our nation. Based on the 2020 data, it is still the fifth leading cause of mortality. And in the 2012, there was an economic cost-effective study that would show us that it has an 8.48 million pesos toll for those patients who are having CAP-MR or community-acquired pneumonia moderate risk, and even 643.76 million pesos for those with CAP-HR. So with those values, okay, those are kind of threatening, okay, because we are in the Philippines, a third world nation. So with this lecture, we would like to share with you the important factors on how we can prevent by giving the vaccination. That's why these vaccination preventable diseases are very, very important. If you can see based on this slide, the most common causative or etiologic agents for our community-acquired pneumonia would be as follows. Based on the Philippine studies, based in the PGH, okay, so the strep pneumoniae or the Streptococcus pneumoniae would pose as the second most common cause of this infection, but in other countries and in other studies, it will pose as the most common cause of etiologic agent that will give us this community-acquired pneumonia. For if you'll be given a pre-test, post-test, or if you'll know some general data, still, Streptococcus pneumoniae would still be the most common etiologic agent that would give us this form of infection. Let's try to talk about the vaccines. We have two types of the pneumococcal vaccine. First, we have the pneumococcal polysaccharide vaccine, which is abbreviated as a PPSV23. And the second type of vaccine, we have the pneumococcal conjugate vaccine, which is the PCV13. Let's try to talk about the differences and the commonalities between these two. For the first vaccine, the PPSV23, let's give it a shortcut like a Pneumo23. The Pneumo23 vaccine would mostly stimulate the B lymphocytes. When I talk about the B lymphocytes, we are pertaining to the humoral-mediated immunity. So if this would activate the B cells, this one would stimulate the antibody because the antibody would be one of the fates of the B lymphocytes, specifically the immunoglobulin M. The IgM would be the antibody which would be mounted, okay, if there's a response or an antibody response after giving this vaccine. If you can recall the physiology of immunity, your pneumococcal conjugate vaccine or PCV13 will not just stimulate the B cells. This has the ability to stimulate both the T lymphocytes and the B lymphocytes. The T lymphocytes belong to the cell-mediated immunity, while the B lymphocytes belong to the humoral-mediated immunity. The PCV13 is said to be more potent because the mere fact of you stimulating the T lymphocytes will be activated. These T lymphocytes, the helper cells, would stimulate and help in the differentiation, proliferation of the different T cells and the different B lymphocytes. That's why if I'm going to compare between the two, PPSV23 and the PCV13, it is said that the PCV13 would have a higher immunogenic effect because it would stimulate both the T and the B lymphocytes as compared to the Pneumo23. But what is one advantage of the Pneumo23? It has a broader spectrum of protection, meaning to say it can protect us against the 23 serotypes of pneumonia. And also the PPSV23 will not actually decrease the incidence of your pneumonia. However, it can decrease the bloodstream spread or sepsis because of pneumonia. As compared to the PCV13, you can decrease the mortality, you can decrease even the incidence of having infection with the Streptococcus pneumoniae bacteria, leading to our community-acquired pneumonia. So after this slide, we'll be able to somehow understand the physiology, the concept, the commonalities, and the differences between these two types of pneumonia vaccine. Here, we can see the different serotypes that can give us the community-acquired pneumonia. On the left part of the table, you can see the most common strep pneumonia serotypes in the Philippines as follows. And in the next two columns, we can see the serotypes that can be covered by the PPSV23. And on the farthest right, we can see the serotypes that can be covered by the PCV13. Those two types of vaccines would have some commonalities in the serotypes that they can cover, but of course we also have some differences. But we have already discussed in the previous slide what would be the advantage of giving this vaccine over the other vaccine. In the next few sessions and in the next few slides, in our lecture, we'll be talking about some recommendations, the risk factors, some of the adverse effects, and how can we compare them with the studies done abroad and in the Philippine setting. So for the summary of recommendations, among apparently healthy adults of more than 65 years old, our senior group of patients, we recommend the use of the PCV13 or the conjugate pneumonia vaccine. Among apparently healthy adults of more than 65 years old, again our senior group of patients, we recommend the use of the PPSV23 or the Pneumo23 vaccine with a moderate certainty of evidence, strong recommendation. Among apparently healthy 18 to 64 years of age, younger age group, we suggest the use of the PCV13 or the conjugate vaccine. Among apparently healthy 18 to 64 years of age, there is insufficient evidence to recommend the use of the PPSV23. So the initial recommendation is that 18 to 64, yes, you can give your conjugate vaccine, but there will be insufficient data as to the giving of your Pneumo23 vaccine. For adults, we also have to consider, because those studies, they made the subjects who are very, very immunocompetent without any comorbidities, and the outcomes were measured after a single dose of either the conjugate or the pneumococcal 23 vaccine. No local pneumococcal surveillance or the ARSP 2020 reports locally prevailing serotypes varied per year, and no studies on subsequential use of the PCV13 and the Pneumo23 were done. Let's try to look at the different outcomes based on the benefits and harms. Of course, giving vaccines, they are not 100% protective, not 100% safe without any adverse effects. So let's try to compare them. So these studies are done in the Netherlands. So let's try to look into the conjugate vaccine, the PCV13 versus placebo. As to all-cause mortality, it shows here no significant difference between the PCV13 versus placebo. In decreasing the incidence of community-acquired pneumonia, this one favors PCV13. Why? Because we can remember, PCV13 can stimulate both the T cells and the B lymphocytes, and we have discussed earlier that the PCV13 can actually decrease mortality, can actually decrease the incidence or the infection with strep pneumo. That's why this one would favor the PCV13 with a high certainty of evidence. How about invasive pneumococcal disease? This would also favor the giving of the conjugate PCV13 vaccine. Adverse events. So 4 weeks after giving the vaccination, but not more than 6 months, it shows here that it favors placebo. Why? Why is that so? giving a vaccine is not 100% safe. Of course, in giving vaccinations, we can observe some local adverse effects like pain at the injection site, some erythema, some redness. So this would show us that as of the adverse effects, it would favor the placebo. Serious adverse effects, no significant difference. What does this tell us? Most likely, those adverse effects are the common, non-serious adverse effects that would be associated with vaccination. So still, PCV13 is still of importance and is of benefit. How about the conjugate vaccine? We've discussed that. Let's try to talk about the PPSV23, the Pneumo-23 vaccine. In decreasing the risk of having community-acquired pneumonia, this one would favor the vaccine, the Pneumo-23, with a moderate certainty of evidence. For the invasive pneumococcal disease, the result would show no significant difference. Let's try to compare the two, the conjugate and the Pneumo-23 vaccine. As to the immunogenicity, no significant difference, but the PCV13 has shown a non-inferior effect as to the PPSV23 with a high certainty of evidence. This would be among patients who are 65 years old and above, the senior group of patients. As to adverse effects, this one would favor PPSV23. Why? Because we have discussed in the last two slides, your conjugate vaccine can also have your adverse effects. And most of those adverse effects are the local, non-serious adverse effects associated with vaccination. How about 18 to 64-year-old group of patients, conjugate vaccine versus placebo? To prevent invasive pneumococcal diseases, this one has a 74 decrease in the incidence, which of course would favor the conjugate vaccine with a low certainty of evidence. Adverse effects, 95.8 to 95%, mostly local reactions, like what we have discussed. Some local adverse effects, erythema, pain at the injection site, which of course this study would favor the placebo. But remember, those vaccines would only give you the moderate or the very, very mild adverse effects. Immunogenicity, of course this would favor the PCV13 because the PCV13 is very, very potent to stimulate both the T lymphocytes and the B lymphocytes. And later on, as you give these vaccines, if you stimulate our own lymphocytes, we will have our lymphocyte clone, we will have this good memory function or the anamnestic function. So the immunogenicity would show a very robust immune response, especially highest among those with a younger age group because they are the ones who are very, very immunocompetent, lesser comorbidities, which would make them have a very, very robust immune response after receiving these vaccines. Outcomes as to the benefit and harm of the PPSV23 versus placebo among 18 to 64-year-old. Decreasing risk of community-acquired pneumonia, no significant difference because we have studied and discussed earlier, it can decrease the bacteremia but not significantly the infection because of the B cell stimulation as compared to the conjugate vaccine, which can stimulate both the B and the T cells. Immunogenicity-wise, PCV13 or the conjugate vaccine was non-inferior to the PPSV. Why? Because of the ability to stimulate both branches of the lymphocytes. Let's talk about some figures, some monetary figures, which is quite interesting. Because we are not earning that much. I think the annual income per year for a Filipino is not that much. But look, if you have this community-acquired pneumonia, you can see the figures there. I can see 6 figures, 7 figures. So in 2012, the economic burden of pneumonia after you have your community-acquired pneumonia moderate risk would give you a toll of 8.48 billion pesos. For CAP-HR, the high-risk pneumonia, it would incur us 643.76 million. 643.76 million might not sound too much for a first world country, but of course we are in the Philippines. We want to help our countrymen, our people in the Philippines, our fellow Filipinos, on how to prevent this disease. How can we prevent having this much expenditure as of this aspect? So let's try to look. Is this cost effective? In Korea, specifically in South Korea, giving the PCV13, PPSV23 for 65 years old and older, yes, it is cost effective. How about in Sweden? Yes, it is also cost effective for both the conjugate and the Pneumo23. How come in England, not much studies as to the cost effectiveness for giving those two kinds of vaccines? Probably we have to look into that. Probably the PCV13 vaccine has been incorporated into their childhood vaccination programs. How about for the other countries? Belgium, Korea, South Korea. Not much studies have shown the cost effectiveness of giving those vaccines for 65-year-old, probably because of the vaccination program that they have in their country during their younger age period. Okay, look at the figures here. 1 in 4 Filipinos are aware of the pneumococcal vaccines. So 1 out of 4, that's roughly 25%. If we're going to look into that figure, 1 out of 4 Filipinos are aware of the pneumococcal vaccine. Also, 1 out of 4 of them are aware of the flu vaccines. So 1 out of 4 is roughly 25%. But how much of that 25% in the population here in the Philippines are really vaccinated? So of all those who are aware, so 25% of those who are aware of the vaccines, only 53% of them are actually vaccinated. In fact, less than 20% of Filipinos more than 60 years old and older are vaccinated. 9% of those who are aware of these two types of vaccines, they did not even get their vaccines, either with pneumococcal or influenza. Why? What do you think is the reason behind that? So we have probed into the details. In fact, of those who are not vaccinated, most of them are residing in the provinces, in the rural areas, lower socioeconomic status, lower levels of education, and sadly, most of them are males. Why? Because they would prioritize treatment. If I get sick, if I get pneumonia, I'll use the money, I'll shunt my money to buy the medicines. Because I think the concept that they have in mind is treatment rather than prevention is highly prioritized. So I hope with this study, we will be able to reiterate the importance of having the pneumococcal vaccines. Here for the PSMID 2018, we're recommending the PPSV23 and the PCV13 to be administered routinely to immunocompetent elderly patients 65 and above to prevent invasive pneumococcal disease. This vaccine, the PPSV23, can be administered routinely to immunocompetent adults, especially elderly, to prevent pneumococcal disease. The conjugate PCV13 can be administered routinely to immunocompetent adults in preventing pneumococcal pneumonia. But look at this one, mortality-wise. PPSV23 and PCV13 may be recommended to immunocompetent adults, especially elderly, in preventing mortality. So what's the beauty of giving this vaccine? You can prevent the invasiveness of this disease. You can even prevent the mortality, with strong strengths of recommendation. Here, just not to cause confusion, these are the different recommendations from other countries like in India, Australia. Here in this slide, also some recommendations from India and Australia. But of course, we want to know what will be the scheduling of the vaccines? How will we recommend it to our patients? So as a summary, among apparently healthy adults, 65-year-old and above, we recommend the use of the PCV or the conjugate 13 vaccine. Among apparently healthy adults more than 65 years old, we recommend the use of the PPSV23. Among apparently healthy 18 to 64 younger age group, we suggest the use of PCV13. Among apparently healthy 18 to 64, there is insufficient evidence to recommend the use of the PPSV23. So as a bottom line, 65 years old and above, we recommend strongly the conjugate and the PPSV 23. 18 to 24 years old, we recommend the conjugate 13 vaccine, and there will be insufficient data for the Pneumo 23 vaccine. So our patients will ask you, ask us physicians, so how are we going to give these vaccines? When are we going to give these vaccines? Scheduling. This table might give you confusion, but I'll give you a mnemonics. You just remember 13 to 23. So if your patient has already received the conjugate, the Pneumo 13 vaccine, after 2 months, in this slide we can see at the bottom part, it says there 8 weeks. So 8 weeks is roughly 2 months. So 13 to 23. If you have received your Pneumo 13 vaccine, the conjugate, the 13 vaccine, you wait for 2 months or 8 weeks, then you can receive your 23. If you have already received your 23, the PPSV 23, you wait for 1 year before you get your conjugate 13. So the magic number or the mnemonic is 13 to 23. Conjugate 13, you wait for 8 weeks or 2 months, then you get the 23. If you have received the 23 first, you wait for 1 year, then you get the Pneumo 13 or the conjugate vaccine. So this would be the schedule of the pneumococcal vaccination. So these slides will be shown in the presentation so you can review and ponder and try to remember. And I hope the mnemonic will help. So these are the references for my lecture. So I hope you learned something, and I hope with this series of vaccine-preventable diseases, we can prevent at least one disease, which is pneumonia. Thank you very much.